Alright guys, Dr. J.A. Graves here from the Physical Therapy Clinical Development Facebook group. Today I'm going to be talking about exercise progressions and regressions for the shoulder. Now before I get too far into the exercise prescription component, I need to talk about a few key concepts that underpin what we do when it comes to prescribing exercises for the shoulder. Now the first concept I want to talk about is the joint-by-joint approach. The joint-by-joint approach is an example of regional interdependence. And basically, what the theory is here behind the joint-by-joint approach is that the body exists in alternating segments of mobility and stability. Okay? So in the ankle, that is a joint that should be mobile. And if we go up the chain, we're going to see that the knee should be stable, the hip should be mobile, the lumbar spine should be stable, the thoracic spine should be mobile, and so on and so forth. So again, alternating segments of mobility and stability as the primary functional need for these joints. Now, what I should note is that when these joints or these joint regions become dysfunctional, they give up their primary need. And that's the premise of the joint-by-joint approach. So again, in looking at this, we can see that the thoracic spine is an area that it really needs mobility in order for the body to function at its best. The scapula, that's an area in which we need stability, and the glenohumeral joint needs mobility. Now what's important to remember is that all joints actually need both mobility and stability. And we know this is true, but from the joint-by-joint perspective, these are the primary needs. And again, these are the things that the joints will give up in the presence of pain or dysfunction. And I talk about that a little bit more here. So what I call a compensatory role reversal is basically, again, this idea that a joint has given up its primary functional need or primary functional role. So in the case of the thoracic spine, when we have pain or dysfunction that causes the thoracic spine to give up its primary need of mobility, it becomes stable and stiff. The scapula, which should be stable and have good motor control, becomes unstable and has poor motor control. The glenohumeral joint, which should be mobile, oftentimes becomes stable and stiff. Okay? And when all these things happen, we have shoulder pain. Or when we have shoulder pain, these things happen. Now, another key component to pay attention to, or that I'm going to introduce you guys to today, is movement impairment syndromes. Now, movement impairment syndromes was developed by Shirley Sarman out of Washington University in St. Louis. Now, what she basically did is for the entire body, she came up with movement impairment syndromes. This idea that we should be diagnosing movement based off of a description of the primary dysfunction. Okay, so on the screen here you can see there's 8 movement impairment syndromes of the shoulder that she talks about. There's scapular downward rotation syndrome, scapular depression syndrome, scapular abduction syndrome, winging and tilting syndrome, humeral anterior glide syndrome, humeral superior glide syndrome, shoulder medial rotation syndrome, and lastly, glenohumeral hypomobility syndrome. Now, all 8 of these syndromes are characterized by a primary dysfunction. And according to her model, if we fix the dysfunction, we fix the problem. So instead of talking about shoulder pain in the context of a pathoanatomical diagnosis such as biceps tendonitis, we would say, the patient has a humeral anterior glide syndrome. This tells us more information. It tells us that, hey, they have a directional susceptibility of movement at the glenohumeral joint to anterior glide. In other words, they might have an anteriorly tilted scapula with an anteriorly translated humerus, which is causing stress on the biceps tendon, thus giving them what we might call biceps tendonitis. But biceps tendonitis alone doesn't tell you enough information. So it's important to classify according to these standards where we're actually looking at the primary movement dysfunction and how that's contributing to someone's pain or dysfunctional movement patterns. So how do we approach intervening with exercise or prescribing exercise. There's three key concepts here that we have to consider, amongst many others. But for the sake of this training, these are the three things that I want to talk about. Okay, first of all, we have to have a thorough examination. Right? We have to be able to identify the key link or the most obvious painful dysfunction and start here. Okay, so our painful dysfunction, this is really going to model the regional interdependence approach, where somebody with shoulder pain, maybe they have they have pain to the glenohumeral joint, and we find that the thoracic spine has a mobility problem. Okay, and that's the most obvious thing in their movement that we see. We start there. That's what we have to address first. And more often than not, when you find the key link or that most obvious painful dysfunction and you fix that, a lot of times the pain and any other associated dysfunction gets better. Okay. We also have to consider the joint-by-joint approach. So we need to consider our examination findings in the context of the joint-by-joint approach, which forces us to ask why. So why is the scapula unstable when it should be? Is it because the thoracic spine is stiff and it shouldn't be? Is it because the glenohumeral joint is stiff and it shouldn't be, and now we're compensating? So consider your exam in the context of the joint-by-joint approach to help you answer the question of why. Okay? And then lastly, consider movement impairment syndromes. All right, if somebody has pain on the anterior shoulder, and then you also find that maybe they've got a stiff thoracic spine, but at their glenohumeral joint, they're residing in a little bit more of an anterior glide, that's something to take notice of. We're going to need to clean up that thoracic spine, but we also have to make sure that we resolve any other dysfunction that might be promoting an anterior glide. So in this case, maybe loosening up that posterior capsule and making sure that glenohumeral joint can sit nicely in the glenoid, or the humerus can sit nicely in the glenoid within the joint without putting stress on the biceps tendon. So a couple things with exercise prescription. Okay, we've gone over a little bit now how to look at the person and see what's going on and appreciating the joint-by-joint approach as well as movement impairments. Now we need to talk about movement prep, and we need to talk about general physical preparation. So movement prep is synonymous with a dynamic warm-up. And this is not something that I don't think this is done very often in physical therapy, but I think it should be done very often in physical therapy. So your movement prep is an opportunity to help promote motor learning and physical readiness. Okay, so when we think of a dynamic warm-up in sport, what does it do? Well, we start to get prepared, our heart rate goes up, we get a little bit of an increase in core temperature, maybe we work on a few skills related to the task at hand. Okay, this is no different. Movement prep in the clinical setting is going to do the same thing. Okay, we're going to prioritize motor control, we're going to prioritize activation of key musculature, we're going to prioritize mobility of key joints, and then we're going to prioritize physiological readiness, or getting the heart rate elevated and warming up the core and getting our temperature up a little bit and preparing for general physical preparation. Okay, so general physical preparation, or GPP, is basically training, right? So I always say that the rehabilitation is training in the presence of injury, and that's what we're doing here. Okay, so we've got movement prep, which is our dynamic warm-up, and a transition into GPP, which is going to develop physical preparedness, and it's going to develop resilience, and it's going to develop robustness. Okay, and in this particular case, we're going to talk about the basic training elements of pushing and pulling, specific to the shoulder. Okay, pushing horizontally and vertically, and pulling horizontally and vertically. Now, I want to touch on one key component here of why we prioritize GPP and why I use the words resilience and robustness. So when we look at a lot of musculoskeletal pain, usually what we find is it's a product of a patient doing something that they just weren't physically prepared for. Okay, so they've got functional capacity demands, and then they have their current capacity. And a lot of the times we find that there's a discrepancy between those two things, ultimately resulting in musculoskeletal pain now or sometime in the near future. So our job, our role as therapists, is to develop robustness and bring their current capacity up to the level of their functional capacity demands. In other words, developing readiness or preparedness for life or for the game or for whatever it is that they need to be doing in their life. So I want to talk about the trainable menu. Okay, so a trainable menu is a menu of progressions and regressions for exercises. Now, this is most commonly used in GPP or general physical preparation and is often used in the personal training and strength world. I use this as a clinician because it helps me to stay organized with my progressions and regressions and make sure that I'm progressing patients appropriately, especially when it comes to exercise selection. Okay. Now, the trainable menu is usually organized by a pattern or a purpose. So you might organize by pattern and say that you're going to do, pushing horizontally, pulling horizontally, pushing vertically, or pulling vertically, or by purpose, which might be, mobility or scapular motor control, or sensory input, or energy storage and release, or any number of things. Okay. So again, organized by pattern or purpose. And the big thing with the trainable menu is it allows us to determine a starting point and then easily progress and regress as needed when it comes to exercise selection. Now, a couple key things here, or linchpins, as I sometimes call them, for the shoulder when it comes to movement prep. So movement prep linchpins would be essential things that we must do in preparation for GPP for somebody with a shoulder problem. Now, your exam is obviously going to tell you what actually needs to be done, but I will tell you that in most cases, if you check all three of these boxes here, then you're going to have a very, very happy patient, and you're going to make some serious improvement in their pain and movement dysfunction. So the thoracic spine. We talked about this a little bit in the context of the joint-by-joint approach and how this is an area that needs mobility. So we need to consider our exam findings and determine if the patient needs extension, flexion, or rotation of the thoracic spine. A lot of times we just assume everybody needs extension, but you'll often find in athletes they actually need a little bit of flexion because they tend to be stuck in extension. So your exam is going to tell you this, but regardless, that thoracic spine needs mobility according to the patient in front of you. Again, whether that's flexion, extension, or rotation. Now, the scapula is an area in which we need to prioritize upward rotation and scapulo-thoracic congruence. Okay, so in other words, if they have a scapular downward rotation syndrome, obviously we need to focus on upward rotation. But even then, more times than not, most people could benefit from more upward rotation. So we're looking at serratus anterior activation. We're working on training that force couple that promotes upward rotation of the scapula. And then with scapulothoracic congruence or congruency, we're focusing on all those stabilizing muscles of the scapula, which would include many of the same muscles that focus on upward rotation as well as a few others. And then lastly, glenohumeral control and or rotator cuff activation. So if you focus on these three things in movement prep, your patient should be very well prepared for general physical preparation. And again, your movement prep serves as a dynamic warm-up, but it also gives you the opportunity to create marginal gains. Okay, so if we prioritize our movement prep and we do it regularly, sometimes daily, we might see marginal gains that can develop over time. So you accumulate these marginal gains and the patient just gets better and better and better, especially when we put strength and power and endurance on top of these primary needs. So this is an example of a movement prep trainable menu for the shoulder. So I'll quickly talk through these exercises with you guys, and then I'll talk about how we can get access to videos of these exercises a little bit later. But this is, again, an example of a movement prep trainable menu for the shoulder. So we've got thoracic mobility, scapular control, and glenohumeral control. You can see that I broke down thoracic mobility by extension, flexion, and rotation. Scapular control is broken down by closed chain and open chain, and then glenohumeral control just has a few listed exercises there. Now, What you will see with the trainable menu is, now in the case of movement prep, this isn't always the case, but it's usually organized in order of progressive difficulty. So scapular control is probably a better description, or a better way to show you that idea. So, in the closed chain, for example, we've got quadruped band clocks. Okay, relatively simple exercise when it comes to scapular control compared to something like a plank or a plank variation. So you can see how we move from something a little bit easier with more points of contact in quadruped versus something a little bit more difficult with fewer points of contact in a plank position. Same thing with the open chain. We've got supine kettlebell overhead reach compared to a waiter or an overhead carry with a dumbbell or a kettlebell. There's a lot more demand required out of you as you work down that list from supine to standing and ultimately walking with a weight over your head. So again, this is an example of movement prep for the shoulder, trainable menu. You guys can use this. If you have questions on the exercises, hopefully I'll be able to answer those when I start posting videos of these for you guys. And if you want videos of these, just let me know and I will get you access to these. So next, the trainable menu for general physical preparation for the shoulder. Now, I've got trainable menus like this for all basically major patterns. So hip dominant patterns, quad dominant patterns, split stance, single leg, etc. But this is specific to the shoulder in that it's upper body focused. So you can see we've got from left to right, we have horizontal push, vertical push, horizontal pull, and vertical pull. And again, these exercises are organized from top to bottom, going from easiest to more difficult. And like I said, the nice thing about the trainable menu is it gives you an opportunity to, establish a starting point for a patient and then progress or regress depending on what it is that their movement or their movement pattern demonstrates. So for example, you might want to start somebody on a push-up, but you find that they can't quite do it. So if you look at the push-up on the horizontal push list, you will see that to make it easier, I could choose an incline push-up, or if they do really well with the push-up and they're ready for a progression, we go feet elevated. So that's a little bit more challenging for them. Okay, so same thing with vertical push. We go from quadruped with more points of external stability up to a jerk press, which is a little bit more of a dynamic movement requiring a little bit more coordination and control. And the same thing holds true for horizontal pulling and vertical pulling, where we go from kneeling postures to standing or adding weight. In the case of a horizontal pull, we're going to go from a half kneeling cable row, which is pretty simple, compared to an inverted row, which is essentially having your feet up on a bench and doing like a TRX pull up with your body parallel to the floor. Okay, so again, I will have videos of these exercises for you guys. If you want them, you just have to let me know, and I will tell you how to let me know here shortly. But again, a great example of a trainable menu for the shoulder for GPP or general physical preparation. I highly, highly recommend you guys create one of these for yourself or use mine, whatever you want to do, it's totally fine. But this will help you stay organized, and it will help you to write programs for your patients and make sure that you're progressing and regressing in a efficient and scientific or just a better way. All right, guys, thank you so much for checking out my exercise progressions and regressions for the shoulder video. Hopefully you guys got something out of this. The next steps for you to take would be to join my physical therapy clinical development group if you haven't already. And if you're currently a member in there, I encourage you to invite a friend. If you're not in my group, this is a group in which I take member feedback and educate based off of that. So you really have an opportunity to learn what you want to learn. It's all about giving you guys what you want. So check out my group, Physical Therapy Clinical Development. You can check out my website, pt.drjagraves.com. Again, that's pt.drjagraves.com. drjagraves.com. Here you can find articles, a link to my podcast, as well as other resources. And then lastly, check out my podcast, Physical Therapy Clinical Development Podcast, which is available on Anchor. Now, if you're listening to this in late April, it's not available quite yet, but please check back shortly because it will be available soon. Again, you can download the Anchor app, or you can check out my website to get a link to the podcast. If you guys want videos of the exercises that are contained within my trainable menu, just comment below exercise or exercises. If you comment below, I'll get your contact information and I will send you all the exercises from the trainable menu. So please share this with a friend, invite people to to join the group, to like my page, and thanks so much for watching this, and we'll talk to you soon.